population health is a huge topic right now. And if you ask 4 people about it, you'll get 5 definitions. So today, hopefully we'll get more clarity. And I'm really excited to introduce the panel. I'll start out with Adam here. Adam is the Director of Provider Enablement from Anthem Healthcare. I've been trying to get as many representatives from the payer side because we hear from the provider, we hear from the vendor, but not so much from the payer side. So Adam, thanks for being here, man. So I'll have you sit down first.
Oh, okay.
Yeah. And we also have 2 representatives from Puerto Rico. And I'm really excited to introduce you guys to Ernesto Santana and Diego. How do you say it, man?
Loinaz.
But Loinaz. I always want to say lion, just his personality. And they've done a lot of work in population health, in technology with Puerto Rico. And I think that their experience might be a harbinger for what is to come for us with everything that we're going through. So this is a rare treat where we have someone from the payer side or from the Puerto Rico side to share their story, their voice, things that we haven't heard before, and hopefully we will pick something up and learn from it. So that being said, Ernesto, Diego, please take your seats. That being said, we'll start out with Adam's presentation. And what I want to do is, we're going to go through the presentation. I'm going to let Adam go through his, and then I'm going to let Diego and Ernesto, and then we're going to go into questions. But I want this to be your session. So as you come up with ideas, please raise up your hand, ask questions, make this as interactive as possible to fight the food coma, okay? So talking about population health after lunch is one of the hardest things to pull off. So I need your help, all right? Cool. Adam, you're up, man. There you go. Get some blood flow going. Water?
All right, good afternoon. So a couple of things, it sounds like I'm one of the first payers to present in front of this group. So just a disclaimer, I am wearing a bulletproof vest under this. So feel free to ask or throw or don't shoot, please, but any questions that you feel are necessary. Another thing that, not necessarily a disclaimer, but a thanks to the organizers is that I asked a question earlier, I used to work for Allscripts and used to travel around the country doing user groups, and something about the meeting organizers always put me first. So I had no content, no material to sort of segue into my own presentations, and people had to leverage it. So thanks to the team and letting me be second in our, I guess, third in the presentations, because there's a lot of great material that I can translate into and, I guess, prove that Anthem isn't just a payer, but we're really passionate about population health management.
Don't shoot.
So as Jeff articulated earlier in the presentation just before me, value-based care is really here to stay. Our legislative branches are passionate about really changing the world of healthcare and having a positive impact on our patients, lowering costs of care, and improving quality. And Anthem feels equally as strong about those initiatives and really driving an impact on all 3 areas of where healthcare is at right now. And I'm sorry, or Mr. Liu had articulated was a really nice translation, and I would actually add one piece to it. He mentioned that workflow is a huge piece of it, experience is a huge piece of it, and that equals outcomes. But I would add one more piece to that, and that's what I'm going to spend most of my time on, and the third is really technology. So within Anthem, we have a methodology in which we want to empower our provider organizations that are working with us in value-based arrangements and enabling them with the solutions, the people, the experience, and the technology in order for them to be successful. So the first thing that I'm going to start with is what we call our alignment solutions. Now, alignment to some may mean one thing, but just in terms of understanding it from a payer perspective. Alignment is really the concept of us defining value-based programs that meet the needs of specific provider organizations. So whether you're a physician practice of one or you're an ACO of many thousands, our alignment solutions pillar, if you will, really spends a significant amount of time working with provider organizations to help us understand what it is that they need to meet the objectives of the APMs and MIPS and MACRA and ACO requirements. These folks are boots on the ground on an everyday basis, interviewing provider organizations around the country, and really beginning to get an understanding of what are the challenges that they're facing in order to meet these objectives, and what we should be doing within our respective programs to help them meet their objectives. And we've really done some really pretty innovative things over the last couple of years, and we just continue to evolve in that space on a daily basis. The second is the experience aspect. So experience can range from technology to patient engagement, to solutions that we offer, to just people and working with them on an everyday basis. These are also folks that are boots on the ground, working with provider organizations every day to ensure that, one, they have an understanding of the program. We understand that this is a really complex environment. There's nothing trivial about understanding what a shared savings program is, what capitation is, and what the transition looks like in moving from fee-for-service to value-based care. These are folks that are equipped with many different assets and assets and solutions that can help provider organizations transition from the world that they've lived in fee-for-service to the world of value-based care. And then lastly is enablement services. And that's what I'm going to spend the rest of the presentation on, and talking to you about what enablement services really means to us. Because when we say enablement services, what we're really talking about is population health management. And so I'm going to spend majority of my time through the next couple of slides talking to you about what we see as population health management and how we see it impacting our industry today. So this was a study that we actually had done a couple of years ago. So just to give you some history on where we've come from a value-based care perspective. About 5 years ago, we initiated our own value-based care program within Anthem. We had stood up our own population health management tools to help provider organizations get access to quality measures, cost measures, risk stratification, and other types of tools that they can embed within their own organizations and begin to work against the requirements that are needed to meet the objectives of a value-based care program. And obviously the industry changes on a constant basis, and it's a daily battle. And we want to continue to provide the solutions that they need to be successful in these programs. Because if you're not successful, we're not successful, the industry's not successful. And ultimately, who gets impacted is the patient. So we did a study recently just to understand where our provider organizations were at and really what the biggest obstacles were for them in adopting value-based care. We had many organizations, when we first got started, they were passionate about it. We had many of them come right to the forefront and said, we want to be a part of your program, let's go, let's go, let's go. And then as time progressed, it slowed down and we got less and less interest. And I think that we saw that in many of the MSSP programs and other ACO-based type of programs. So we conducted a survey to really get an understanding of why is it that provider organizations aren't jumping on this bandwagon of value-based care. And what we found is that the number one response was that they tend to lack population health management capabilities. There are a ton of other studies out there that I found that support this. And it was really reassuring to us that what we're finding is not anything of being inaccurate or really just being a siloed study that perhaps doesn't allow us to take a whole lot of action on. There's obviously some other rankings here in talking about organizational readiness. Clearly there's a lot of change happening in the industry today and with various mergers and acquisitions. In fact, I just gave a presentation on mergers and acquisitions within value-based care, and just in Q1, there were 235 mergers and acquisitions closed across healthcare facilities across the country. which is pretty incredible. And in fact, in 2016, merger and acquisitions within the hospital space accounted for 22% of our total GDP spend in healthcare. Gives you an idea of how much organizational change is happening and what that does to their readiness in being able to take on value-based care. Capital and cash flow, obviously these tools and solutions are not cheap. When we're talking to other vendors, or you're talking to other vendors, obviously a big obstacle that many organizations have to overcome, especially when they're trying to work through this transition of fee-for-service and value-based care, and just basic local market dynamics, patients not being ready to make these types of changes, perhaps lack of connectivity or just resources to help move into this world of value-based care. So this is kind of a busy slide, and I wish I kind of would have reformatted it to start from the ground up. But this is really our vision from a value-based care perspective in population health management. There's a lot of great segues that Mr. Liu has provided me, and reaffirming that we as a payer are really not a payer when it comes to our vision of population health management. We're really sort of on the vision and on the cusp of what many other cutting edge solutions are in terms of enabling our provider organizations that are taking on value-based care and giving them the capabilities to meet the triple aim. So I'm going to start at the bottom. We've talked a ton about data already, right? And I read an awesome quote just the other day about if you don't have the data, you're just another person with an opinion. And really that's where this all starts, right? And having the facet of data that enables you as an organization to get the metrics, to have accurate quality measures, to have accurate risk scores, and to provide you with the tools that you need to help stratify the patient population that's appropriate to your area, not to what we see across all of the markets. So there's a facet of different data sources, and I'll say the number one complaint that I've gotten ever since I've started at Anthem when it comes to something as trivial as quality measures is that you'd be a lot more accurate if I could send you more data. So that's really where this source of data comes into play in enabling provider organizations to contribute data to the program that they're participating in, so we can give them the most accurate results possible, which in the end really provides more incentives for them as a participant in our program. Equally, when you start working with all these different sources of data, there's some really key aspects to what needs to happen with that data before you can ever get to some of the actors, and that's what I'm going to talk about here in just a second. The first is what I would call bi-directional interoperability. And Jeff, again, provided me a nice segue to talk about interoperability, because this really isn't about bringing data into the Anthem platform to contribute to your value-based care program. But equally, we know that you have solutions on your end, whether it be a data warehouse, whether it be any other type of solution, where that data needs to be consolidated and needs to be shipped back out to you for your own purposes. Because obviously our platform's not going to give you everything that you need to meet your other objectives that you might be having within your organization that may not align with what we have within the Anthem value-based program, and it may be just a local initiative. And because there may be data coming from multiple sources, it gives you an opportunity to take advantage of some of that integrated data that I've talked about here on the bottom. Equally, configuration is a huge deal. So this is really more from our perspective of how we can remain nimble with where the market is going and how frequently things are changing from provider request perspective, from what the market is telling us needs to change, and having the ability to quickly and nimbly accommodate to those changes. So having a configurable logic engine and having configurable tools that we can put in the hands of our subject matter experts and enabling them with the tools to meet our provider organization needs. And then lastly, and most importantly, is the security aspect and operational reliability. So being a solution that supports 32 unique states across the country in various value-based care programs. Security is of utmost importance, and also having the infrastructure to give you access to the data on a 24/7 basis, and giving you timely and accurate data is of utmost importance. So as we move from the platform, we begin to get into some of the insights. So I talked to you a little bit about the data, but really from a data integration perspective, this begins to translate into not only are we taking data from various disparate sources and providing them as insights to you within the program, but equally leveraging the data within the platform that we provide within our value-based arrangements and integrating the data that's entered. So we have care management programs that get enabled within our value-based care program, and other types of supplemental data that can be entered within the platform, and enabling you to, if those get hand keyed, those have to get fed back into the system to produce insights and other types of outputs that come through the program. Probably the most important thing here is the analytics. So now that we have all the data, whether it be claims or clinical or ADT or any other types of data, incorporating that back into the analytics that really is the bread and butter of the program. Providing you with the gaps in care that have an impact on the total shared savings that may come out of the program. Cost and utilization obviously is a big one, understanding those that are frequently admitted or are frequent flyers of the ER. Pharmacy reporting, so looking at the various medications that a patient may be on and their behaviors of where they may be going and getting medication. One thing that we're evolving in is the ad hoc aspect. I'll say we're not quite there yet, but this is super important because it's all nice and well when we provide you quality measures and risk scores and things of that nature. But many times, if you're working with a population of 20,000, you really need the ability to take that patient population from 20,000 to maybe 2. You've seen the pyramids of being able to stratify and manage that top 5% of your population because those account for 80% or 60% of your total costs. This is an area that we're continuing to evolve in and giving you those types of tools to stratify that patient population down to those singletons for you to do outreach and management on, and really having an impact on the performance of the program. And lastly is risk and predictive. I've talked a little bit about this. We spend a fair amount of time on providing risk tools and models to provider organizations because these typically require various licenses. And so for us to give you as much risk type of scoring that applies to at least the Anthem population really goes a long ways in many different provider organizations. Lastly is workflow. And this is an area where we're growing in. I would say this is probably the area that is where we're going for the most part. We've deployed a number of care management programs where we've integrated workflows between provider organizations and Anthem care management, where there's bi-directional data exchange and sharing care management data that we do on our side, and equally care management activities that happen on the provider side, and providing that transparency amongst provider organizations and care plans. Equally, just providing access to various enrollment and eligibility type of information and making that available to provider organizations. And then patient outreach. This is becoming a bigger one within our value-based care programs and providing you the tools that you need to do various outreach.
Okay, Adam,
Great.
We'll have more when we get to the panel, but thank you very much. This was very important.
That's great.
Very important. And this is, first of all, do you guys enjoy that? Yeah. And this is why I've been trying to get more payers to come out, because I'll be honest, a lot of these, I didn't know you guys were working on this. I really did not. And the more we hear from you and the more you get feedback from the group, I think it expedites what we're all trying to achieve. So thanks, Adam, for coming out.
My pleasure.
So, all right, now we're going to switch gears a little bit here and talk about something that we've never talked about in this forum, and that is population health. There you go. My wife tells me I'm loud, so I didn't think I need a mic. So one of the things we've never talked about before in this forum is population health, really looking at it from a country's perspective, if you will. And today, I'm really excited to present to you Ernesto and Diego to talk to us about a little bit about their history, a little bit about their journey, some of the lessons learned that they picked up, and what are the things that might be warning signs, if you will, for us that's really looking at tightening our belt and transitioning more into population health. So with that, Ernesto, are you going first? Okay, so I'm going to call up Ernesto Santana.
Thank you so much, Ian. I really want to thank HIMSS and everyone here that we've just had such a great experience in meeting and getting to know everybody. So I really appreciate the opportunity to speak to you today about something that, like Ian said, may or may not be, a harbinger of things to come with the things, how they're shaping up stateside. And I should make a small note, it's not a country, we are part of the United States.
Yes, sorry, my bad. Yes.
So
I was hoping none of you would catch that.
It's a easy mistake to make because, it is far away from, the mainland, and although we're making waves in the news recently with some of the things that are happening there. So just a little bit about our company. We're IT healthcare consultants and technology integrators. We help we started actually as a spin-off of basically another entity, and we're in charge. We have clients in Puerto Rico primarily, and we're in charge of managing their technology infrastructure. In essence, we're between our clients, we probably manage about 80% of the population in terms of the infrastructure that we're managing. So our clients are, we actually are a partner of the Blue Cross, we're a technology partner with them in Puerto Rico, as well as other entities there. And so we basically help them to, come to, in essence, the new models that are taking shape stateside, and we help them come to from the compliance side, technology side, and all IT security, and all sorts of other areas that we help them with. And I want to give you a quick, since we are in Southern California, a little bit far away, I want to and I want to give a little brief geographical lesson.
This slide was meant for me, so don't worry about it.
And this is maybe one of the most important takeaways here. This is not Puerto Rico. This is Costa Rica. It is a country.
How many thought it was Puerto Rico? Right? See?
Yeah, so they're similar tropical environment, but reality, this Puerto Rico is here. Some of you may or may not know that. So we might have taken a cruise there, but not quite remember where it was. So we are a U.S. territory. We have been for many years, over 100 years. And we operate similar to a state. We have a governor, we have legislature, local legislature, et cetera. So, and our laws are based on the U.S. Legal system, and our Constitution was ratified by Congress, et cetera. So, to set that aside, we're in this with you guys in many respects. So, what we want to do is bring a little bit about the experience that Puerto Rico has had in the last few years. It's a very interesting, I would say, a test case for how the legal frameworks that are taking shape today. We've already experienced them in many ways, and as Adam was talking about before, unless you really have data that you've seen and frankly you've lived with, really we're talking about opinions. So we're actually been in the trenches and experienced and seen the effects of, cap block grants and, how we've managed to effectively work within a very limited set of funds. And we'll go into that a little bit. So these are just a little few fun facts, I guess, of Puerto Rico. We've been a U.S. territory since 1898 during the Spanish-American War, along with Philippines, Cuba, and a few other territories. And we're still a U.S. Territory, unlike some others that have been, obviously had their independence. So we actually currently have about less than 3.5 million folks, and they're U.S. citizens, I should say, Puerto Rico residents that live on the island. And you do not need a passport to get there. You just fly as if you were going to go to, any other state. Although you probably use a plane to get there. Or a large, yeah. I'll have to try that one. In terms of GDP, we're running right around $100 billion a year U.S. By the way, it's a U.S. currency also system, so and it's about $28,000 per capita is how it breaks down. Life expectancy-wise, it's about 79.38 years. It's a little higher than the U.S. Probably, some of the effects of living in a tropical island that might help, I guess. This is just a little bit of the overview. I'm gonna pass the mic soon to Diego, and so what Puerto Rico, in terms of the healthcare overview that we can give you here, and we actually were kind of assigned a small slot, so now we have a little more time to go in depth, but very quickly, quick facts, we have 1.5 million Medicaid eligible in the population, and the budget is about $2.8 billion annually, and it breaks down in the following way. There's a state block grant, and this is locally funded. No federal money comes here, so it's about $1.2 billion. It's 47% of the total budget. Federally, we receive about $321 million each year, and that's capped. So we really can't. It's not in the States. It's a different system. So also there was a Obamacare one-time grant of about $6 billion spread over 8 years, and that has helped offset some of those costs that we've been dealing with locally, and able to do meaningful use and bring in health IT, et cetera. In terms of Medicare, it's about 700,000 folks on Medicare, 75% of which is on a Medicare Advantage, so it's managed population, and it's called Platino locally. And the interesting thing here is the reimbursement that we see locally is about close to 60% less than you will see in a average in a setting in pretty much anywhere in the States. So you understand the economics here are sharply different than what anybody definitely in California or any other state has in terms of funding to do these programs. Additionally, there's about 800,000 that are on commercial plans through their employer, and 350,000 uninsured. In terms of household median income, we're probably, I think it's half of Mississippi, so you get an idea of the median income there. And if you see the population, this actually came from the Census Bureau, and if I go back one slide, the population, this was, I think, 2015. If I go back one slide, we're actually on a downward path here, population-wise. There's been, because it's such an easy, way to essentially move out of Puerto Rico to, say, Florida, New York, or California, then we're kind of in an interesting dilemma. And I think Diego can speak as to, we're even obviously losing many of the physicians to the point where some of the very, specialties are, we maybe have 1 or 2 doctors still locally on the island. So I think with that, I'm gonna pass it over to Diego. This just kind of give you a little overview, and before he takes the mic, Diego actually worked for the Office of the Governor in Puerto Rico as a healthcare advisor a few years ago, and so he has been pivotal in making many of the decisions, policies in Puerto Rico to help the population, and obviously now from the private side also continue in that quest. So I'll leave you with Diego for a while.
Thank you. And thank you to HIMSS, to you all for having me here with you today, especially Leroy, Ian, thank you very much. And I wanna echo what Adam was talking about the importance of alignment. Very early on in my career, I had a mentor, Dr. Mercado, and he spoke continuously about, from the payer side, the importance of alignment. And today you'll see why that is true for Puerto Rico. So, I'm going to give you a very quick history about population health in Puerto Rico. So back in 1975, Dr. Arbona basically said, we're having an access problem. We have 78, actually you can see them in the previous slide. Those lines are actually 78 municipalities, and right down the middle of the island, we have a mountain range. So getting physicians and patients together was really tough before then. So in 1975, he basically said, you know what, we need to improve our infrastructure. So we're gonna set up clinics, facilities in each town, and then we're gonna build regional hospitals to refer, obviously, the acute cases back to them. So that improved access back in 1975. That is what it was so for 2 decades, but it was challenged because the big problem was that paying, government salaries, paying physicians to visit these towns was extremely difficult, and the keep up of these facilities was also a challenge. So what happened was that since the system was private versus public, the indigent population would go to these facilities, and the private population would go to different, altogether, hospitals. In 1993, the Governor Rosselló, basically said, we're doing away with that model. We're going to bring in managed care into the Medicaid program. We're going to contract. We're going to cut the island in 10 regions, and we're going to assign a region to each managed care organization. And the other big item there were many items in that law, but the other big thing was that if you you were a private physician or hospital, and you did contract with that managed care organization, you needed to contract for Medicaid, and you could not discriminate. So you couldn't say, well, I take care of Medicaid patients on Friday, or they have to wait until I take care of my private patients. So that was a big deal because it unified the populations within all facilities and physicians around the island. So that rollout took a few years, and I would like to make a special note, because when they did that in 1993, they simply forgot about the facilities. So they started selling those facilities that were built in 1975, and most of those facilities took a downturn. Most of them closed, or simply were not profitable because the financing for the Medicaid program was based on services, not on the cost of running a facility. Noteworthy also is that in 2001, we got under the Medicare Plus Choice, later named Medicare Advantage program, was established in Puerto Rico. MMM broke the ground, and that is important, as I explained further in our history. So from the perspective of technology, before 2003, we had very little technology to handle our populations. The big item was that since we needed to comply with HIPAA in October of 2003, 5 payers, I was fortunate to be part of the founders of that initiative. 5 payers, we got together and we said, we need to comply with HIPAA. So let's support a single clearinghouse that can help us transmit electronically, EDI obviously. And that really took off the ground, and eventually in less than 5 years, we had most of the providers transmitting it electronically. Most of the payers as well joined HEY, which was the name of the collaboration. And I should mention that the only organization that did not join HEY or contract with the clearinghouse was the Blue Cross Blue Shield organization, and basically the reason was that they were already EDI compliant, that they could receive and transmit with the physicians and the hospitals. Now, to the point regarding alignment, even though that Blue Cross Blue Shield could transmit directly with the providers, they did not obtain support for their tool, because they did not bring in the providers into the fold, contrary to the other payers and the clearinghouse where they did bring value to the providers. They started saying, you're going to submit your claims through us, but we're going to provide you a dashboard of what's going on with your claims, receive reconciliation on your claims and all that. So the providers really took upon them to support the initiative. And that really improved, at least on the claim side, not HL7 or clinical side. In 2006, the rest of the insurers in Puerto Rico, they started joining Medicare Advantage, now named accordingly, thanks to the MMA. At that point, our elderly population really started taking better care of our population. That was really noteworthy, and I'll mention some results in a few seconds, but that was key in regards to our elderly population. So in 2009, as you know, high-tech came along, and Puerto Rico also participated. The territories, and when I say territories there, I mean, I'm not forgetting our sister and brother territories, is that Puerto Rico has such a large population that we represent 98% of the population in all 4 territories. So when we talk about the assignment that Congress made in regards to funding to territories, it really means almost the funding for Puerto Rico, because it's 98% of that allocation. But at that point, we also realized that our funding was so inadequate, and we needed to start lobbying Congress unified. So public-private payers, providers, we all got together and said, Congress, you need to start looking at us from a different perspective, because we do want to improve our population health, but we need the funding. And you could say, well, yeah, you guys are a territory, you're not a state. Why money should be allocated appropriately. Well, the thing is that, as Ernesto was correctly saying, we need to comply with all federal regulations. If only in those laws enacted by Congress that refers to the states and not the territories are we excluded. But in most of them, all the regulations, just imagine this, all the regulations that you guys need to comply with, try to do that, try to accomplish your own objectives in a third of the budget. It's nuts, okay? So that effort, thank God, is still going on. So we regularly visit Congress jointly, and that is difficult to see because being a small island, we're only 100 miles by 35 miles. We're like, sort of like a rectangle. We have a lot of competition amongst ourselves because there's no more room. You have nowhere to go other than obviously chew a piece of the pie from the other guy. So that is certainly a challenge. In 2010, Ernesto was making reference to this. The Affordable Care Act allocated $6.3 billion to Medicaid. But when they did that, and I was part of Governor Fortuño's efforts in Congress to obtain matching instead of in the regular block grant approach that the Congress has with Puerto Rico, try to move to the matching program that all states are part of. What they did was, and I was in the room with a senator who said, well, Diego, if you guys need monies for Medicaid, well, you guys have a lot of business on the Medicare Advantage side, so we can move and allocate accordingly. And exactly that's what they did. They basically increased Medicaid funding by 42%, but then they decreased Medicare Advantage premiums by 21%, which were already lower. So we basically netted out. We moved around the funding, or we didn't, Congress did. Then in 2013, and I'm gonna digress a little from healthcare, we had a lot of bond financing for our infrastructure. And the problem was that politicians would get those funds from bond creditors, but they would use that money for operating expenses of the government. Okay? That led to a whole series of events, and in 2013, the scandal broke, and the government of Puerto Rico's credit just decreased significantly. That is certainly a huge downturn for the economy in Puerto Rico, which will, as you will see, will impact healthcare, so it's worthy mentioning it. In 2014, the ACA comes into effect under the individual and the small group mandate. And Puerto Rico in 2010 had been allocated $925 million to set up our own exchange since we were apart from the continental US. The governor, two successive governors balked at the idea and instead chose to take those $925 million and use it for the regular Medicaid budget. Puerto Rico had at the time 8% of its population was uninsured. It's now at something like 6%, but certainly still a problem from a population-wise perspective. 2016, from a society perspective, it's a negative year for us. Deaths exceeded births for the first time. That is not good news in a society and from a demographical, economical. Most of our population, the young generations, are leaving town. We used to have, 15 years ago, we used to have 4.5 million people. We're at 3.6. And for the reasons that I'll explain later in a second, that migration will probably increase. So what happened was in 2016 that Congress enacted Promesa Law. The act basically set up a fiscal board to improve the economic situation for the island. The way it works is that the government of Puerto Rico needs to propose a plan to restructure the financial woes. That process has come through. It was approved, however, by the fiscal board. But as of recently, the government did not comply with several of the demands that they need or conditions of that plan. So in light of that situation, the governor filed for bankruptcy under the Promesa Law. Puerto Rico did not have access to the U.S. bankruptcy code, but Title III of the Promesa Law does allow Puerto Rico to file for bankruptcy. So in that process that I was mentioning a minute ago, the fiscal board was demanding for a $1 billion cut from the territory's funds. And the governor basically said, you know, we can do 300 million because otherwise we're going to affect too many people. Okay? So that stalemate ended when the plan was approved. However, since now the governor filed for bankruptcy, and now there's a federal judge appointed by the Supreme Court, it remains to be seen if the fiscal board will prevail, in which case, if you recall at the beginning of Ernesto's presentation, our Medicaid budget is 2.8, and the government of Puerto Rico funds 47% of that. So we cut off $1 billion out of a 2.8 budget. And then on the American Healthcare Act bill, Puerto Rico is going to go from $1 billion assignment down to $298 million federal assignment. That means that the Medicaid program in Puerto Rico is basically dead. If that happens, rest assured that in the next 18 to 24 months, around 500, conservatively speaking, 500,000 people will flock to the U.S., okay? We've explained to Congress that if the same people who are in our Medicaid program move to Florida or New York, which are the main states where Puerto Ricans move to, the cost of handling that same population is between $10 to $12 billion on those states. It doesn't make sense. So, unfortunately, as you know, the American Healthcare Act is still, just like Jeff was saying, it's going to take weeks or months. And the problem is that the governor has already said that we only have money to pay for the Medicaid program until December of this year. So think about that situation, and then let me tell you if you can really handle quality objectives under budget cuts. Puerto Rico, the Medicare Advantage plans in Puerto Rico. Ernesto already told you that our longevity is higher than you guys, right? So, but just imagine this, the Medicare Advantage organizations in Puerto Rico are at 4 stars. Under the quality program in the Medicare Advantage program, we're at 4 stars. The average in the US is 3.66. We've been able to accomplish quality objectives under funding limitations.
Diego,
Yes.
could you describe a little bit about the fragmentation of the provider landscape in Puerto Rico? Do you have large health systems? Do you have very small individual practices? How does that work?
Thank you. We actually had a slide on that. So let me run by you the numbers. So we have around 9,000 physicians. That number used to be much higher. We're losing in between 400 to 600 physicians per year. And like Ernesto said, we have some specialties that we have only 1 or 2 subspecialists. So it's a concern. We have 62 hospitals. We have around 900 pharmacies, 800 labs. Which other item I should say? Around, we've been even losing insurance companies. We used to have close to 20. We're down to 10 out of consolidation and small outfits that have been closing. On the hospital side, the largest network, they're a client of ours, and we meant to bring in one of the executives to speak to you all today. The largest private health system has 13 hospitals, around 6 clinics, but what is particularly relevant that organization has thrived in spite of funding limitations because they also have an HMO. So back in the 90s, they had the foresight of integrating their HMO and the point of care. And as of today, they're looking and they're asking for Intricare support in integrating that information up and down. But I do want to mention, to answer your question, that payers have really played a part in sharing of information and across the board, because slowly but surely they have shared for quality purpose, for case management purpose, they share that information down. Not necessarily, like Adam was saying, not necessarily completely accurate or timely, but it definitely has been instrumental in getting us towards information sharing between all constituents. But again, talking about alignment, in Puerto Rico, we've had 3 efforts to establish health information exchanges. 2 of those efforts came from payers, but they did not involve the providers, so that has limited success. And the Puerto Rico government enacted a law to establish a health information exchange. It was, the infrastructure was built, and we're losing it. It hasn't been implemented accordingly because we need the workflows. We need to get everybody involved to submit the information. So, yeah, I want to touch on this slide just a second. Those are round numbers, but Puerto Rico's, the U.S. expenditures are around 9,200 something, and Puerto Rico is a little lower than that. The G20, the Organization for Economic Cooperation and Alignment, I think it's the name, and Cooperation and Development, issued a report that says the G20, their expenditures in healthcare are around 4,000. So we all know in this room that the US has the most expensive healthcare system in the world. Puerto Rico is even below that, but we're much closer than you guys. So I think it's relevant how Puerto Rico, in spite of its economical and funding woes, has been able to comply with US standards with a lower budget for handling our population. Yeah, this is a great slide. This is in the Medicare Advantage arena. Those are the Puerto Rico counties in terms of reimbursement. So it's very dramatic. Fortunately, that has improved lately. I thought I had, because the call letter, published in 2016 call letter for Medicare Advantage and this year's, which is published for the 2018, bumped the reimbursement for Puerto Rico. Puerto Rico had been penalized because we had a 75% penetration on the Medicare Advantage compared to you guys here in the States, where it's usually between 25 and 35% penetration. But since we were, I want to say successful, but since we had a large penetration on that market, CMS understood that we were getting too much funds, so they thought that we could take a cut on the Medicare funding. It's nuts, and the stories get worse, Leroy. I think if I could share some takeaways from our experience in population health, funding has played a large part of what happens to take care of our whole society. I think in order to operate under financial constraints, managed care has expanded across the island, obviously. Since they have, they have the dollar in their hands, they've been able to implement technology strategies to allow for sharing of information, just like similar to what Adam was explaining. And as we look forward to our fiscal cliff, right? We need to be even more efficient with technology. The technology piece is critical for Puerto Rico to really come across in these times, tough times. If you have any questions.
All right.
Diego, going back to the change in reimbursement for, I think it was Medicaid, where you got the Medicaid increase, the decrease in Medicare, and the $6 billion one-time payment over, I think it was 8 years. At the end of that 8 years, though, it's going to be a net loss because you lose that out overall. Isn't that correct?
Yes, sir.
Okay.
So, since the American Health Care Act bill promotes block grants to the states, let me answer your question, just going over that issue regarding the block grant. So just before the Affordable Care Act back in 2010 was enacted, our block grant was at $300 million and change. The Affordable Care Act is enacted. They assigned that $6-point-something billion, which supposedly was supposed to sunset on 2019. But what happened was that Puerto Rico, along the initial years of the Affordable Care Act, asked CMS under the discretion of the administrator to allocate funds faster. So that's why, even though that it's supposed to sunset in 2019, the funds are running out on 2017, on December. That's one of the challenges of being under a block grant, right? So if your circumstances change, and for example, we had which was in the news, the the Zika, the mosquito disease, that really took a toll on for a year in the cost of the healthcare expenditure. So that ate up part of that budget. That's just to mention one situation that wasn't expected, but under a block grant, well, that's it, right? So that's what you have. That's one of the challenges for you all. If you move towards block grants, you really need to be sensitive and careful about managing that budget and within the state conduct those allocations.
All right, well, Diego, thank you so much. And Ernesto, this, again, it's now that we're in that transition period where we're looking at healthcare policies, and we're doing a lot of speculation, right, as to what might happen. It's good to have Ernesto, Diego talk to us about what happened when you try to use legislation as a tool to kind of dictate where healthcare goes, and the repercussions that you don't foresee if there isn't enough flexibility. So I think, we're in that time where we're looking at the Affordable Care Act, looking at what to change, what to move. And again, I keep going back to public policy. Folks in this room know a lot more than the folks in DC, the folks in Sacramento, so we need to let them know what we see is working or not working. Otherwise, people make decisions, they think it might work out, but if they don't have the knowledge, things like this might happen. So that being said, before we go, I see folks are leaving already. Leroy, please stand up. And all the folks who helped put this thing together, I want to give you guys a round of applause. The thing with HIMSS is that it's really a lot of work, but the good thing is the pay is great. So as a volunteer organization, it really takes a lot of time out of the days of folks who are helping out. So thank you for acknowledging them. Now I want to ask a few questions, and then I'll throw it back to you guys if you have a few, and then we'll round out the day. It was actually, in terms of time, perfect. I didn't know, it's already 3:30. It was great presentation on you guys. Now, Adam, one of the things that, I really want to get the payer in here is so that you can have a conversation with mostly provider and vendor group. So if you had a magic wand, what would be the one thing that we can help Anthem, in this case, expedite some of the goals that you had more towards the top in terms of getting better data, getting more bi-directional communication? What do you need?
I would give it one word, and that's collaboration. It's a big term that we use in Anthem, and we're seeing more and more of it. There was a question earlier around, what are the challenges around adopting some of this? Technology is technology, and providers, and even in many cases, us as payers can't change that.
Right.
But if there's collaboration, then, we're really in this together. And if we have that level of collaboration, then it allows both sides to be successful.
So, okay, so let's make this tangible. For folks who are in the Anthem plan, how can they collaborate? What do they need to do?
I think the first thing is adoption of tools.
Okay.
I shared a lot of the information that we provide within organizations, and we have many different success stories of organizations that have adopted tools. And we want to continue to evolve in those tools, and the only way that we can evolve, it's no different than working with a vendor, is giving us the feedback that we need to improve the tools to make you successful in your arrangements.
Cool. So any of you here on the Anthem plan, please make sure that you collaborate, because again, that is ultimately the goal, why we do what we do. This whole event is to make sure that through collaboration, we both get better information, and then we can deliver better care. I know that the frozen yogurt machine is great, but really, it's about exchange of ideas, and it's, you know, between the phone calls and the emails, nothing like personally getting up to a person and asking the question, so collaboration. I'm going to jump to Diego and Ernesto here. So you guys are in a very special situation because you're helping First Medical Group, right? And they have the payer side, the provider side, and you're helping right now to standardize, I use that word loosely, the IT infrastructure and using IT, kind of like our theme, to leveraging technology to improve healthcare. You mentioned previously that these systems aren't really, you know, planned out. It's more you buy one system here, so they're all in different states of IT, readiness, maturity. How do you do that?
Well, it starts with, I think that word collaboration is very important, and partnerships. And I think that this forum, this organization has helped us get, you know, pretty far along those way in terms of, along that way in terms of partnerships, and getting the right technology, and the right processes. And so I think it's just baby steps. I mean, we're maybe about, I would say about at least 5 to 7 years maybe behind technology-wise, from here. So those lessons learned, you know, when things didn't work out, those are important because we can, you know, with the you know, restricted funds that we do have, and foreseeably that we won't even have, you know, not spending money on failure is important. So, you know, I do encourage organizations, you know, to reach out to us and, you know, let us know, hey, if you want to, you know, partner with us, and let us know, hey, you know, in terms of an EHR or a health information exchange or interoperability, and all those things that are going to help. And that has already happened. I mean, frankly, in the last 18 months, you know, I've met many people here, and you know, we did a tour of UCLA, and that was, you know, very eye-opening, and you know, getting to know the folks here has been very, very instrumental to getting that to start happening, really. So it's a long path to you know, getting on par. But I think we're on the right track.
Right.
Yeah.
So, Diego, you talked a lot about the struggles you've had, you know, talking to Congress and working on the funding. Again, their mindset is, you know, the 50 states within the country. They don't translate well when you're looking at a territory. Is there any hope in your mind with the turmoil going on? What is your gut feel with all this? I think your body language says it all, but yeah.
This is going to sound counterintuitive, but as the crisis nears,
Okay.
I think our chances improve.
Really? How so?
I don't think, even though that the situation in Congress is sensitive right now, you know, bipartisanship and all that, but I don't think they're going to leave the indigent population in Puerto Rico out on the cold. I don't think that's going to happen. You know, really the concern there is that whether Congress will have a chance to enact a healthcare bill in time before December.
Right.
That's the concern.
Wow.
But I don't think Congress is going to leave us, you know, behind or anything like that. We do know that it's going to be less funding that we used to have. I guess that's
Given.
the writing is on the wall.
Right.
But I don't think we're going to close down the program. As it is, it looks that way.
Okay. Cool.
But yeah, apparently we're going to have to keep on working under extreme circumstances.
Right. So if ever you guys are working with less funding, remember Puerto Rico. Puts things into perspective. Carl?
Diego, kind of a follow-up to that is, how likely do you think that projection of the number of the migration that you spoke about to Florida and New York of your residents?
Actually, I left the computer in the car. I can share with you a presentation by the executive director of the Puerto Rico Statistics Office. And he goes into detail about what that projection might be if all things remain the same. When he gave that presentation back in February, the situation regarding bankruptcy and the American healthcare bill were not around still. So he's expecting that we get another 100,000 people migration this year. But I haven't met with him since last time I saw him in February. I'm pretty sure, and the consensus is within the healthcare space, that the Medicaid situation will prompt those numbers to increase dramatically. Everybody's in consensus. But I can certainly, if after the conference, you share the email, I'll send you the presentation.
Good.
I have Carl's email.
Super.
All right, any other questions, guys?
Can I add something
Yeah.
to complement Ernesto's answer? Puerto Rico has a HIMSS chapter. Okay? So it's not only the lessons that your individual organizations can share with us as a bridge to sharing it back there. I think there's a bridge within your own organization. And there are lessons on both directions, right? We have lessons of how to accomplish quality and regulatory objectives on a limited budget, and you guys certainly have a wealth of information, especially in the technology, IP area. So HIMSS is, I think, a great bridge for that to happen,
So,
which you had proposed.
yes. So just so you guys know, one of the things we're really looking at is how do we partner with either organizations or groups that are doing different things, but towards the same goal, right? Improving healthcare. As you've heard earlier, we have the Ronald McDonald House. They're helping families with very sick kids, so we're partnering with them. And with Diego and Ernesto, we actually were at UCI yesterday and UCLA, and both institutions expressed the desire to share information, and not only that, look at different ways of partnering so that whatever lessons they've had here, they could also share with Puerto Rico, and that would, drastically help improve just from a knowledge base. So one of the things that came out of that was doing like a week intensive in healthcare, where we would have folks from Kaiser, UCI, UCLA, talking about healthcare, cybersecurity, IT development, and folks could come, go through that, and literally within a week, change the mindset, or at least have that different vantage point in healthcare. So we're constantly looking for opportunities to do that. So if you guys have any suggestions, let me know, let anyone here know, so that we can implement that. And again, Diego, Ernesto, it's bi-directional. We're learning from you. You're giving us hope that if our budgets are cut, we can probably survive. But there's definitely some tweaks in the way we do things that's needed. And with Adam, they're reaching out. A lot of the sidebar conversations, payers kind of have a bad taste in people's mouth for different reasons, but it's different when you see a person like Adam here, who's reaching out and saying, no, we're all in this together as we truly are. So if you guys don't have any more questions, let's give the panel a round of applause. Thank you so much, guys. This was great. And I'll give it back to Leroy. Thank you.